an AI read 11,000 brain tumor slides and out-diagnosed 5 neuropathologists in 12 minutes, not 12 days. So should you trust it? That tension, speed, and performance versus evidence and accountability runs through everything this week. Welcome to This Week in Healthcare and AI, the show that takes the most important new developments in medical AI and asks one question: does this actually change what we do for patients? This is AI in Healthcare. It's Saturday, the 20th of June, 2026. This week, an AI that subtypes brain tumors from a routine slide, Ambient AI moving into the revenue cycle, a hard look at when to trust these tools, the top randomized trials straight from PubMed, and the payment and policy moves that decide what reaches the bedside. Let's get into it. First, the week's headline study. A model called Hetairos predicts 102 methylation-defined brain tumor subtypes straight from a routine H&E slide. It was built and validated on 9,600 patients and over 11,000 slides from 11 centers across 4 continents. It makes a high-confidence call in about half to two-thirds of cases, and on those, accuracy is 0.87. The striking result, from histology alone, Hetairos scored 0.68 against 0.30 for 5 board-certified neuropathologists, and it turns a roughly 12-day molecular workup into about 12 minutes. The authors are careful, though. Molecular testing stays the gold standard, and they open-sourced the code. So does this change practice? Not your protocols, not yet. Where it matters is access. A fast, slide-only provisional subtype could help centers without methylation arrays or triage, which cases need urgent molecular testing. Before it changes anything routine, we need prospective multi-site validation, a regulatory path, and a clear plan for the third to half of cases where the model isn't confident. Bottom line, don't rewrite the pathway, but let it reshape how you think about diagnostic access, with a human and a confirmatory test always in the loop. Story 2: Ambient AI grows up. Abridge, one of the best-known ambient documentation companies, is expanding well beyond the scribe into coding, prior authorization, claims, decision support, and research, backed by a strategic investment from Eli Lilly. The signal, value is moving from the note itself to the revenue cycle around it, and the productivity case is firming up. Philips Future Health Index for 2026, over 2,000 clinicians and 20,000 patients across 10 countries, found 46% of clinicians saving at least 132 hours a year, more than 3 working weeks. Half reported capacity for about 8 more patients a week, and 65% increased their AI use at work. Does it change practice? It already has ambient documentation, is clinical AI's first real killer app. But as these tools reach into billing and prior auth, watch automation bias and note bloat, and remember, you signed the note, so you own the output. Story 3: The Skeptic's Corner. 3 findings worth sitting with. First, over-trust. People over-rely on AI medical advice even when it's wrong. Confidence outruns accuracy. Second, and subtler human and AI interaction cuts both ways. The way you prompt can steer a model toward more accurate answers, but also toward more harmful ones. Third, a framing I'd put on every deployment: compared with what? Don't judge a model against perfection, judge it against the care patients actually get today. So, treat AI as a second opinion, never an oracle. Earn trust task by task, verify against a trusted source, and mind how you ask. Now, a new recurring segment from the literature, straight from PubMed. 2 randomized trials this week, both on how clinicians and AI work together. First, in Nature Medicine, Google and Stanford tested their AMI system on complex suspected genetic cardiomyopathy. Blinded subspecialists preferred the AI-assisted assessments 47% of the time versus 33% for cardiologists alone, with fewer clinically significant errors, 13 versus 24%. Second, in NPJ Digital Medicine, a 70-clinician randomized trial, whether the AI went first or second, clinicians did better than with conventional resources. 85 and 82% versus 75, though still just below AI alone at 90%. 2 more worth knowing. The Proteus trial, a 20-hospital NHS study of AI stress echo, where the value came from cost and efficiency rather than accuracy, and a UK replication where clinicians underused the model, posing only 30% of their questions to it. The through line: AI assistance helps, but only if you actually engage it, and only if the workflow is built for it. With thanks to PubMed and the National Library of Medicine. Story 4: Follow the money and the rules because they decide what reaches patients. The big one, the 2026 CPT code set adds 288 new codes, including ones for AI services. Think coronary risk assessment and burn wound imaging live since the 1st of January. AI is now billable, and that changes incentives overnight. In the UK, NHS England is putting £20 million behind rolling AI chest X-ray tools to every trust by 2029, building on more than 4 million lung cancer investigations already supported. In the US, the Health Department issued a request for information on using AI to cut costs, and the World Health Organization published a discussion paper on the opportunities and risks of AI in health policy itself. Why it matters: reimbursement changes behavior faster than any guideline, and governance is still catching up. And the teaching point: the habit that protects you. A performance metric is a signal, not proof of benefit. Before you let any tool change a decision, ask 4 questions. 1. Validated against what comparator, in which population and setting? 2. Does it improve outcomes or only predict them? 3. Who checks the output at the point of care and who's accountable when it's wrong? 4. What happens to the patients it gets wrong? It's the same discipline evidence-based medicine already applies to drugs and devices. Association is not benefit, and a number is a signal, not a target. So, the week in 4 lines. 1. Diagnostic AI is moving from single images to subtype level triage. Impressive, but molecular testing still rules. 2. Ambient AI's time savings are real, and the value is shifting into the revenue cycle while governance lags. 3. Be a calibrated skeptic, earn trust task by task, verify, and mind your prompts. 4. Payment and policy will shape adoption more than any single model. What I'm watching next week: prospective and regulatory data on diagnostic models, whether those new CPT codes actually get paid, and the first real-world audits of ambient AI in coding and prior auth. That's this week in healthcare and AI. If one of these stories changed how you think, share it with a colleague who's practicing without the time to read these papers. New episodes every Saturday night. Subscribe, rate the show, and send your feedback and disagreements. Listener mail makes this better. This has been AI in Healthcare. Until next Saturday.